So this patient is 87 years old, has a dense nuclear cataract, Brunescent, pseudoexfoliation, and doesn't dilate very well. Also, you may notice the cornea has a dry spot and some opacification near it. So I will certainly want to have excellent visualization as we do this procedure. And to maximize that visualization, here I'm doing the 2.4 keratome entry. To maximize that visualization, I'm going to put some oxycoat on the surface of the cornea. It kind of fills in defects on the corneal surface, and it'll give us the best possible visibility. So here I'm going to stain this anterior capsule with trypan. Doesn't have to stay on very long, just a few seconds is good enough. And then a little lidocaine, followed by a lot of viscoat. And if I inject the viscoat distal, the air leaves. Pupil gets as big as it's going to get. And if it stays that big, I won't have to do anything to it. And now I'm going to take this Provisc with 25 gauge needle on it, and I'm going to puncture the anterior capsule. We all saw the stria there as I did that. And we'll watch and see, because we may need capsule retractors. Keep in mind, the older the patient is with pseudoexfoliation, the more likely they are to have a lax zonule, for the simple reason that they've had pseudoexfoliation longer. So I'm going to make a rhexis that's around 5 millimeters, a bit shy of that maybe. And notice we're not wetting the cornea because we don't need to. Maybe every 5 minutes or so we'll have to apply more oxycoat, but we don't need any yet. So I've done hydrodissection and now viscodissection. Now what do we know about the zonule so far? Not much. The Capsulorhexis was, okay. I saw some stria. But I'm going to be watching for signs of zonular laxity, if you will, like a hawk. And at the first sign that it could be an issue for the phaco, I would go to capsule retractors. So we may need them. Reset the CD. So I want to maximize infusion capacity here. That's good. By turning the infusion sleeve. You may notice I was on position 1 as I inserted the chopper through the tight incision. Makes it much easier to do that. Just taking some Cortex off this Brunescent nucleus. And okay, so first, no hurry here. Hold that nucleus still. Keep it in good focus. Sculpted bowl should be big enough that we can see into the bottom of it. Pretty steep angle now on the phaco tip, and getting a bit of a red reflex down there. And I think we're ready to chop. Now that was an impaled chop, where I went from position 3, ultrasound, to impale the nucleus, and then to 2, to hold it with vacuum. And that didn't really chop well. I'm going back to do it again. And when I went back to do it again, all I did was put the phaco tip a little deeper on the sculpted wall so I could hold it better. So now I'm going to get this quadrant epinucleus. And I just manipulated that quadrant so that it was sideways. And I'll drag it centrally here sooner or later, or encourage it to come centrally with the chopper. And let's go now quadrant removal. That's a good sized quadrant in it. So I'm not going to let it come up towards the cornea. Notice that the chopper is actually on top of it. While I kind of whittle it down to size. Alright, so we successfully removed a quadrant. Now let's divide the rest of it. Yeah, I think we got that one divided. Now we got a heminucleus to divide. Okay. Now you can see we've only used 60% of power. And we're going to increase the power here to a bit more. Yep. 80. So now we're at 80% of max. We usually don't go higher than that even for brunescent lenses, unless we get into black, red-black nuclei. Then we might go up to 90 or even 100. You can see how much staining the capsule has helped us here. We know where that anterior capsule is all the time. And when you're using high power levels, you sure don't want to get near it, meaning you don't want to strike it, because you'll get a radial tear. But I'm able to see that capsular margin all the time. So if I move a little bit into the periphery, and by that I mean just a couple millimeters, I can still see where the anterior capsule is. Notice how I intermittently discontinue ultrasound. And the reason I do that is simply to make sure the tip gets to cool. Torsional is thermal friendly, but ultrasound is still a heat generator. Okay, it's time for INA. So there's no reason to push the envelope. I've never had a corneal burn with a torsional instrument. And I don't want to have my first 90-degree INA tip. Now, I can tell you that the posterior capsule is more anterior than its normal anatomic position. It's right there. And it's flaccid. It's floating around. So I want to be careful. I'm using the spatula to hold it back.
What did you say about the posterior cap?
And you can see the cortex coming off of it. And just aiding its removal with the spatula there. So now all we have left is the subincisional. It was a little bit down at 6 o'clock. We'll see about that in a minute, but Now spatula protecting PC, cortex removal. And there's that little bit that's left down here. A little tangential stripping there. More than it looked like, huh? Subcapsular epithelium removal. Notice how you still see the dusky stuff on the capsule? That's the pseudoexfoliation stuff on the anterior part. You're not going to remove that. Okay, so now we're ready for our OVD injection. This happens to be Provisc into the posterior chamber and our IOL insertion. And you can see those opacities. And by the way, you may also recall we never did wet the cornea once during the case. The OcuCoat has remained on the cornea. It's the only OVD, the hydroxypropyl methylcellulose, that I recommend for that purpose. The others don't provide you with the visualization through them, or they don't flatten out so nicely. Let's have a chopper. Now I'm watching that haptic there. It hasn't released yet, so I might just go in and release it. Nah, it just did release. Okay, so now we'll remove OVD from behind. I'm not going to decenter the IOL a heck of a lot to do that, you know, in an eye with Pseudoex, and you know, we know the zonul's okay, but it's not 100%. A little piece of nucleus there. Okay, so time for some stromal hydration after we remove the INA tip. And if you do a little stromal hydration on each side, and then kind of sweep back and forth in the center like this, and then I let that sit there for a while. There's a little chip floating around. That's why you always want to irrigate through your side port, because it's so often a little chip will be over there. Let's see if we can encourage that to flow out of the incision. I think we just did, by irrigating distal to it. And if you irrigate distal to something, then you know where it's going. It's headed proximal. Okay, IOP's nice. And now it'll be elevated. I like to elevate them at least once during it. I think it kind of just helps to seat the floor of your clear corneal incision against the roof. And now let a little fluid out and put vancomycin in. I think I just see another little piece right there. How do you like that? So I'll take some BSS and we'll irrigate that guy out. And then I'll put some more vancomycin in, because in doing this, and I think it just flowed out the incision. It's so easy to leave a chip, as we all know. They can hide behind the iris, as that little piece was. And serendipitously, that one came out. One wonders how often a piece will stay behind the iris forever and get slowly absorbed over months without causing any significant issues. It's a real number. Okay, so now the vancomycin again. You might say to me, gee, what if you didn't get that vancomycin out with the first irrigation? You just gave 2 milligrams. Here's the good news. 2 milligrams is fine. We sometimes give 2 milligrams to people who have severe blepharitis, etc. It's okay. But we are done here. We've got a well-centered IOL, and the zonule I don't think is any the worse for wear.